Welcome back to part two with Brush Up on EMS with Bob on abdominal emergencies. We're going to talk quickly about pain. So somatic pain, that's more with the musculoskeletal system. We're talking about the knees, the joints. That's the pain we deal with when we have those achy joints or the cramping. Now with abdominal pain, we have abdominal pain and discomfort. That visceral pain, that's that dull, achy feeling. My tummy just hurts and it hurts right here. And it originates from the organs in the abdomen. It's a diffuse sensation, so we really can't say exactly where it's at, but it's right here. This is that intermittent pain. It comes and it goes. Word for that is colic, and you might result from having distension in your abdomen or contraction of a hollow organ. Persistent or constant pain usually means it's dealing with a solid organ. If it comes and it goes, we're talking possibly about hollow organs. So kind of keep that in mind. So if the pain comes and goes, we're talking hollow organs. If the pain is constant, it's a solid organ. Parietal pain, that's when the parietal peritoneum is being inflamed, and we describe this as a sharp pain. So maybe they're having a leaking in the abdomen of one of the hollow organs, so they're having a pain that comes and goes, and then it also is a really sharp pain. It's severe and constant, and it localizes to a specific area. They can actually point out where it's at. Tearing pain, if they're having abdominal aortic aneurysm, they're going to have a tearing pain, and you're going to ask them, can you describe the pain to me? And they're going to say, it feels like I'm being torn on the inside, and that's a retroperitoneal location for that aorta. This can be caused by trauma, or they could just have an aortic dissection, aortic aneurysm, and just be sitting here like we are today. And then that referred pain that I just talked about in the previous video, that's where you have distant locations that are being affected. When the appendix starts having problems, the periumbilical, basically around your belly button, starts having problems first. So that's kind of a referred pain, but the nerve pathways are overlapping, and they return to the spinal cord, so that pain sensation is transmitted from one system to another. So that's that referred pain we talk about. So a couple conditions, and we're going to buzz through these pretty quickly. But appendicitis, they're going to have nausea and vomiting. They're going to have pain when you do palpation, and then they're also going to have that rebound tenderness. It's going to be a sudden, severe increase in pain when the appendix ruptures, releasing that items into the peritoneum, and we have that parietal pain, and it's sharp. Peritonitis, that's inflammation of the peritoneum, and this irritation causes contraction of the abdominal muscles, so it's going to be really tense, and their abdomen is going to be very tight. So as you're pressing on it, it is going to be very tight. It's going to be, as described, hard. It may not be distended. It could be, but distended is more like gas in the belly, but it's going to be rigid. The abdominal wall is going to be rigid, and they're going to have pain. Cholecystitis, that's where the gallstones are in the gallbladder or the inflammation of the gallbladder. This comes from eating fatty foods that worsen these conditions. It could be diet, it could be genetics. The severe right upper quadrant with epigastric pain. That pain is often referred to in the shoulder. Pancreatitis. So we have our gallbladder and then our pancreas. Inflammation of the pancreas, which is over here, it kind of overlaps either side. The liver is over here on the right side, but the pancreas kind of overlaps. And it's common in patients with chronic alcohol abuse because alcohol gets converted into sugars, and that causes problems to the pancreas because it seeps in. And they have epigastric pain, so it's high, and they can have referred pain to the back of the shoulder. Are you going to be able to do anything for these abdominal pain emergencies? Not really, just identification. GI bleeding. Okay, so this one is important to know because you can do a few things for this. If they're vomiting, if it's upper or lower, if they're vomiting, make sure you're watching the airway, maintaining your airway breathing circulation. If they're having diarrhea, watch their fluids because you might need to do some orthostatic vitals for these people, okay? To make sure that if their blood pressure is dropping when you stand them up. Along with the gastrointestinal bleeding, it could be minor, it could be severe. Blood eventually exits one of two directions, and these are caused by ulcers in the gastric system from the highly acidic juices. This can go on for a long time for people. I've seen some pretty severe GI bleeds. Dark stools that are maroon or black, or as described as tarry. Coffee ground emesis, it smells. Their pain can be absent or it can be super severe, so keep those things in mind. And then an abdominal aortic aneurysm is that ballooning or weakening of the inner wall of the aorta, and it tears or separates from the outer layers. It's a dissection. It's tearing away. When it ruptures, that's when we have the bleeding. But the aneurysm is that ballooning of the vessel. The dissection is when it's separating, and then it ruptures when we have that release of blood. They have sharp tearing pain in the abdominal, in the retroperitoneal radiating to their back, and you might even feel a palpable abdominal mass that might be pulsating. So keep those things in mind. You may not even find pedal pulses, or you might find unequal pedal pulses. And where are you going to find your pedal pulses? On your feet. So with that, watch for shock, and keep them warm, keep them pink, keep them dry, get them to the hospital, keep taking vitals, rapid transport. And so those are some of the things I want you guys to remember when we talk about abdominal emergencies, some of the big name ones that are out there and some of the little name ones. But all of abdominal emergencies require us to be attentive to what's going on. Look at the areas, if it's that pain, that sharp pain, maybe it's a solid organ. If it's that dull pain, maybe it's the hollow organ. It requires us to be attentive to where are these going, where is this happening, what can we do for it? Nothing really, just maintain our vitals and airway breathing circulation. But identification is the biggest key in abdominal emergencies. So if you guys have any questions, don't be afraid to ask in class. And as I always say, have a great and safe week.